So Dr. Bay's gone through quite nicely the physical examination, and now I'm just going to link the physical examination into what to order and when to order it. Many of you on your pre-course survey filled out that you're quite comfortable with making the decision for imaging, but some people were looking for even some quite, fundamental guidance, so hopefully I'll help with that. The imaging in children is increased in complexity due to the increasing ossification throughout life, and also the fact that the physes are present. A small fracture sometimes in a child can actually represent a large injury because the piece is quite big, but the piece of bone that came off was only small. In my talk, I'll cover the indications, selecting an appropriate investigation. I'm going to mainly focus on trauma because that's probably the biggest number of patients that you'll see presenting with hand and wrist problems. We'll cover the digits, hand in general, and wrist. We'll briefly go over some swellings and lumps because they're also quite common, and then that difficult teenager that presents with wrist pain. What should we do with them? In trauma, it's important to have a very low threshold for imaging. Fairly innocuous falls can actually present with fractures, and the exam findings can be quite underwhelming. Any mechanism that has a penetrating injury to it, has a significant crush component to it, is high energy, falls from play equipment that are high, trampolines, all that present with pain probably should be imaged. The initial description of the digit, sometimes a finger will come in, and if it's a fairly acute injury, the swelling may not be great yet, but the family will say it was off to the side, and that if it was reduced on the field. In adults, that's much more likely to be just a simple dislocation, but in children, it could very well be a fracture, in particular a physeal injury. Clinical findings that Dr. Bay covered: swelling, focal tenderness, abnormal alignment, and that tenodesis effect. If any of the fingers do cross and don't appear to be coming down into the normal cascade, then that's definitely an indication for imaging. If a child persistently defunctions an area, they're busy people, they're going to get back to what they were doing before, and if they're not getting back to it within 48 to 72 hours, even if you can't elicit focal tenderness, it's probably, and they've had a trauma, worth a plain radiograph. Almost all scenarios, AP, lateral and oblique x-rays are the most appropriate investigations. The exception is the scaphoid. You don't have to order the individual views of the scaphoid series, just putting scaphoid series and that will be imaged. If you can possibly narrow it down to a digit, it's much better than getting hand x-rays because you'll focus on that particular area. However, we've all had little kids who you just can't get near them. You can't work out where's particularly sore, but they've got a mechanism and they're persistently not using the hand. So ordering a bigger field is appropriate then. In terms of swellings and lumps, not all swellings are ganglions and flexor sheath cysts, but most of them are. And if it's a completely classic presentation, it's in a classic location, so a ganglion's on, either the dorsum of the hand or the volar aspect of the wrist, and in children they're fairly equal in incidence, and it fluctuates with size and it doesn't have other symptoms associated with it, then it's perfectly appropriate not to image it. However, if it falls outside of that algorithm, then imaging may be appropriate. Plain radiographs are not commonly helpful if you think that you've got a cyst. However, if you've got a hard mass, there's a possibility of a foreign body, and in actual fact, a lot of the children, or some of the children that we see with foreign bodies, don't come with the headline that they ever had a penetrating injury. This girl with the thumb just presented with an injury many, many months before, and the x-ray showed that she actually had the retained glass. If you're just wanting to make sure that your diagnosis of a mass is that it is a cyst and that it isn't something more significant, either a vascular lesion or a solid tumour, then ultrasound is actually quite good at just making that simple differentiation between simple cyst and solid lesion. MRI, if you're using MRI to assess a ganglion, really needs to be with contrast to tell you whether or not you've got a mass versus a simple cyst. And so therefore, in most scenarios, you don't need an MRI because it's probably not going to change your diagnosis unless you're happy interpreting the results of the report. These, to me, and I think we all find this, are the most difficult patients to determine the best imaging for. It's the sort of wrist pain presenting. Almost always it's worth getting plain radiographs before going to advanced imaging. More commonly than not, the plain radiographs are going to be normal. However, it gives you the reassurance that there's not another significant pathology, a physeal injury, a stress reaction occurring, that a period of rest or observation before either referral or advanced imaging is performed. Most of the time, probably waiting for referral and advanced imaging is appropriate because then the provider can make a decision that you're referring to whether or not an arthrogram is indicated. What we don't want families to have to do is to have two MRI scans because we're uncertain whether there's, you know, a TFC tear that would require an arthrogram to help us elucidate that diagnosis. So the key points, I think, are in trauma have a really low threshold for ordering plain radiographs, and almost always the most appropriate initial investigation is a plain film. That even if a report says that there's a small fragment, some of these small fragments are you know, fairly insignificant, like a small volar plate avulsion fragment. However, sometimes it can actually represent a large piece of articular cartilage with just a small metaphyseal component that's come off. Advanced imaging is actually not commonly required, especially in trauma, and that if a patient is coming to us, we always look at the actual imaging study, and if they could just go by where they had the imaging taken, pick up a disc or hard film to bring to us, that's invaluable. Otherwise, sometimes, unfortunately, we repeat imaging. Thank you. A patient has the persistent radial-sided wrist pain and you decide that you're going to refer, which is what most often you'll do. If you're not and you're just going to observe them and you still think it's a scaphoid injury and you want to just re-image them in 2 weeks, they really need to be immobilised full-time until such time as their repeat imaging occurs. We have trended to either do repeat plain films at 2 weeks. Some families I know are requesting to know the diagnosis earlier, and if we haven't seen a scaphoid fracture on a plain X-ray, in general a CT scan is less likely to show it, and if we're going to choose one advanced imaging, we would choose an MRI scan because that will show bony edema even if the fracture itself is not displaced.
If you worry about scaphoid injury, do you order just a normal wrist X-ray, or do you need to specify scaphoid?
No, scaphoid is the exception to your general AP, lateral and oblique. For a scaphoid, you'll order a scaphoid series, which includes an ulnar deviated view with some flexion in order to actually bring the scaphoid into its longest profile. But you just order the scaphoid series and that will incorporate that image.
When you're splinting that afterwards, do you want just a cut-up splint, or do you want to do like a belt splint to include the pump so that it happens naturally?
So we would tend to cast immobilise somebody that we think has a suspicion for a scaphoid fracture, so not a removable splint. And whether you choose a thumb spiker or a simple short arm cast, the literature doesn't support one over the other. Our personal practice is to use a thumb spiker cast, because children are so active that this just locks them up a little better, and I think that the morbidity for a child is minimal. And so the increased immobilisation, as Dr. Bay mentioned earlier, is invaluable.
One other point of clarification. If we have a finger injury, I think a lot of people order a hand X-ray, but if you actually know which digit is affected, you can order a finger X-ray, right, which is a more coned down view of the finger. Correct?
That's right. So ordering the individual digit, or sometimes it's 2 digits if they've had like a hyperextension injury, and if you order index and middle finger, they'll actually do the X-ray with the fingers like this, whereas otherwise they'll be doing sort of the baseball spread, and you won't necessarily get the fingers as far apart. And that's especially if you think you've got sort of a middle or a proximal phalangeal injury. And the more information that you put, so if you actually put that it's over the, you know, their tender on the extensor side or their tender on the radial side of the wrist, the report will come back and they'll mention whatever you put. Whereas if we just do pain and wrist x-ray, they won't focus on the scaphoid or they won't focus on the thing that you're particularly questioning.
Does putting history of the mechanism of injury help? So that will they...
On a request?
Yeah.
I think it does help. I think that both the mechanism and the clinical exam findings, but I think the clinical exam findings are probably even more important.
People should know that when you don't put it in power chart, when we don't put it in power chart, all the stuff we put in doesn't necessarily get transmitted to the radiologist. So when we send over, I sometimes send over a very detailed request to the radiology, and I'll call and the radiologist say, I never saw that, that wasn't entered.
Right.
So
sometimes it's that if you pick like a pre-populated indication for ordering it, like pain or fracture follow-up, and then you don't go and take out that and put in your own sentence.
but we don't have, we're not
Okay.
No, so most of our doctors don't order the X-ray in power.
Oh, I thought you were saying somebody else puts it into power chart.
We send a printed requisition
Yeah.
from our own system that just says hand X-ray.
and I might put all that detail in.
And then
But somebody else enters it and doesn't put that detail for you. Right.
the secretarial person
Yeah.
that's
That's- Right. So that's very difficult because you're providing the information and then not getting the feedback.
Very good.